Hi everyone, I'm so pleased to be introducing our two speakers today. Dr. Hannah Janeway is an assistant clinical professor of emergency medicine working clinically in the emergency department at the West LA VA and White Memorial Medical Center. They are also the enhanced case management physician lead for UCLA's Homeless Healthcare Collaborative. In 2018, they co-founded and currently co-direct Refugee Health Alliance, an NGO that provides medical care and medical legal assistance to migrants and other vulnerable populations in Tijuana, Mexico, including a large population of LGBTQIA+ migrants. They also organize in Los Angeles and at the border on issues such as border and jail abolition and removing law enforcement presence in hospitals and other parts of civil society. Dr. Janeway is particularly passionate about finding ways for healthcare providers to utilize activist strategies and privileged risk-taking as a mechanism to promote and support social justice and change. And Dr. Dr. Calderon Vargas is a trans-fronteriza general physician who believes that every person, regardless of where they're from or their personal stories, have the right to receive the best trauma-informed medical care and that no human being is equal. She considers herself an activist first, an educator second, and a medical provider third. She is a radical fat acceptance advocate, and she is co-founder and co-director of Refugee Health Alliance since 2018, again, an organization that works in Tijuana, giving free medical attention to refugee, migrants, and other displaced persons. Dr. Calderon is also a professor of border health at the Medical School of the Autonomous University of Baja California. Thank you.
Okay. Nice to see you guys all here today. Thanks for inviting us. And we're really happy to be talking to you guys about something that we're both pretty passionate about, which is how to kind of do border health in a way that's anti-oppressive and not repeating the same mistakes that we've seen over and over again, where people go and provide care that really reinforces or reproduces like colonialism or imperialism from the United States. So our talk today is going to talk a little bit about kind of the work we do, but also kind of how we think about border health in general. So there is some kind of theoretical parts to this that I hope you guys will enjoy. Okay. Let me just try the arrow.
You do this one? Nope. Where should we point?
Okay, there we go. I'll just use them. Okay, so these are four photos of different borders around the world. And I think, does anyone know what these borders are? Like, does anyone know top left? Top right, bottom left, or bottom right?
I think the top right.
Top right?
I think that's the West.
Yeah, that is the border in the West Bank, between the West Bank and Israel. Any other ideas about these other borders?
I'm pretty sure the top left is the border with Mexico.
Yeah, that's the US-Mexico border. But it's really hard to tell, right? Like, they all kind of look the same because they all basically serve the same purpose. What you have to understand about borders, which is really what you need to understand before you can understand at all about providing healthcare and border environments, is that they're really not natural divisions, right? They're very much man-made divisions. And these man-made divisions were made along ideological lines that were drawn through and by political power. Most of it was colonial power, really. All of these lines, almost all of them, were drawn through colonial power. And these other two borders that you see down here, this is the border between Egypt and Gaza, and this is the border between Turkey and Greece that's keeping out migrants who are coming from the Asian diaspora.
Okay.
Okay, so one thing that has become more common is that all borders are getting more and more militarized. And it even has a theoretical word, it's called securitization, securitization. It's the perspective that migration and all like human movement is like a state problem, like a police problem that needs to be stopped. Not as it is that it's normal, that it's natural, that people move, that people have moved for ages, and they'll keep moving. So the only thing that has happened that has been constant is that it gets worse and worse and worse. And we can tell you more examples later with all the policies that the US has made for the US-Mexico border. So one example of this is something that happened 3 weeks ago. In the same building that we have our clinic, there's 2 shelters. One of those was attacked by the military, the police, and well, the Guardia Nacional, it's sort of the military, but not. It's just another name to give money to another arm of the military. And they knocked on the door of the shelter where only women and children live. And they tried to break it so they could go in. And because of that, we went to the press and told everybody this is happening. Please make it stop. We need justice, safe spaces need to be, the shelters need to be safe spaces, at least for women and children, no? But the next night, they came and did it again. So right now we're fighting that through trying to build policy to make that never come again, or at least make it as illegal as it can be.
And I think, you know, the militarization of these borders, which are man-made structures and really represent these sort of infrastructural barriers to health. I really like this photo because I think it really demonstrates it very well. This is a project that an artist did at the US-Mexico border where, you know, on one side you could sit on a seesaw and on the other side another person could sit on a seesaw and they could play seesaw together. And if you kind of look at this photo and you look who's on the left and who's on the right and you think about what sort of like healthcare these people are able to receive, it's completely different, right? But because of this one structure that exists. So borders in of themselves as structural and infrastructural violence prevent health equity. And I don't mean to say that like, you know, just at the border do you have health inequities. People actually carry with them, and this has been well studied, these health inequities with them when they cross across borders, because those borders continue to exist. And so these are just two studies that look at different groups of populations in the United States. One of them looked at undocumented Latinos who reported they were less likely to receive blood pressure and cholesterol checks and less likely to have received excellent or good quality of care and more likely to receive no health or health care information from doctors, even after adjusting for potential confounders. And they compared them to other like Latinos who are also going to this same clinic who had documentation status. So even if you cross these borders many times because you're classified as illegal, you continue to carry these health inequities with you. You're gonna go to a lot of talks on asylum medicine, border health, and I guarantee you this is gonna be one of the first slides that you see. And it's gonna basically show you that there are these different categories that we put people in, right? There's like migrants, and there's stateless people, and there's internally displaced people, and there's refugees, and there's asylum seekers. And while those concepts are helpful when you are trying to advocate for people within what is now considered to be the legal framework in this country and in other countries to decide who has the right to move, we essentially reject these categories because it does place value on who is able and who is worthy of having safety and who is not. So, for instance, like if someone is considered an economic migrant, they will be denied asylum. Even if the same structural forces and the same structural violence cause these people to flee, the same forces that cause asylum seekers to flee, even if those are the exact same sources, there are people who are placed into one category and people who are placed into another category. We're essentially saying that some of those people are more worthy. And that doesn't make sense if you really understand what's causing migration. So this is just like one example that you can look at, which is if you take, say, gang violence in Latin America, a lot of it was actually created in the United States itself. So there was some mass migration because of economic violence towards Latin America, a bunch of different free trade agreements. You can go back and read United States imperialism, a lot of different civil wars that the United States had their hands in, and a lot of people fled to the United States. When they fled to the United States, especially to Los Angeles, they ended up in areas where there wasn't a lot of economic privilege or power. And so in those areas became the creation of what today we know as like gangs. Those gangs were created, and then those people were deported back to their countries of origin, where those gangs then proliferated. And then more people migrated because of gang violence from those countries to the United States. And so that's just like a really good example of how like economic violence, which caused the initial migration, ended up causing gang violence, which caused a second migration. And this kind of wraps it up all together for people in a way that I think is really helpful, in realizing that there really is no difference. Everyone is kind of migrating for the same overall reasons, which are essentially capitalism, imperialism, and white supremacy.
Okay, so we work in the Mexico-US border. Tijuana was the first place that we worked at. I'm from Tijuana, and Tijuana is, well, without traffic, like an hour and a half from where you are standing. So I was going to comment on the picture. I was going to give you a hint. You can drive there. Like one of the borders that we are talking about right now, you can just go and visit. And probably a lot of you can visit, go to Tijuana, and come back. And have you ever seen that as a privilege? So a lot of people in Tijuana have this privilege as well. And it's called transfronterizo cultura, like a transfronterizo culture. And we also have been having 80% of the deportees that Dr. Hannah talked about come to Tijuana since the 70s. So we are accustomed to migration and for different types of it. Okay, what's been happening in Mexico? Mexico, a lot of the violence and narco violence comes in the states that are in the center part of Mexico and the south. So there were usual roads to come up to the north. And most of the roads went to Tijuana. But after the securitization, that everything has become more hypervigilancia, hypervigilance, hyper-policed. All these roads have changed. So the roads that used to have like NGOs taking care of them, now they cannot pass through there. And now they have to go through other roads that are more dangerous. And dangerous as places in Mexico that's not Tijuana. Even though Tijuana is the third most dangerous city in the world, it actually, when you were there, you can see that there are many more dangerous cities, like Matamoros or Reynosa, where we now have a clinic at, Reynosa specifically.
And one of the interesting things that like I have been doing a lot of reading on recently is, you know, a lot of these routes, which are also the drug trade routes, are also the routes in which arms are traded. So while you think of drugs coming north, you can also think of arms going south. So one of the big exchange for drugs is actually arms that are coming from the United States, which is something that's not talked about very often.
Yeah, 98% of arms found in tiroteos, shootings in Mexico, are from the US. 98%.
So this is just like a little brief history of the asylum crisis that we've witnessed at the US-Mexico border. And I just want to say that this goes far back before 2016. This is just a very rapid overview. This has been going on for a really, really long time, all the way back to, you know, the beginning of what we consider to be, you know, the United States. But here at the US-Mexico border, when Sika and I started getting involved, there initially was the system that was called metering, which was an appointment system by which you'd basically show up at the border, and this group called Grupa Beta, which was kind of a really nebulously situated group because you're technically not allowed to restrict people from requesting asylum. And still, yes, would give you a little piece of paper with a number on it. And every day the United States would decide how many people they would let across, and you had to wait until your number was called. And that sometimes could take years.
2 years was the most
that we witnessed. Yeah. And then in 2019, there was the Migrant Protection Protocol, which is kind of funnily named, so it's definitely not protecting migrants. And during that time, people who tried to cross into the United States would be sent back to Mexico if they were pending their asylum case. And between 60 to 90,000 people were returned during that time to await their court hearings, which was absolutely dangerous and unfair, and also led to many people's asylum claims being denied because most people had to represent themselves in an asylum court. Having gone to asylum court and testified there, I would lose an asylum case if I represented myself. So, you know, it's a very difficult process. So because they're all concentrated in one couple of cities, most people lost their asylum cases because of this rule. And also many more people had poor health outcomes or died because of this rule because they were relegated to staying in Mexico when they had urgent health problems. And in Mexico, the public health care system is not ideal or optimal for most people who are migrants or deportees. And then in 2020, we saw Title 42, which you guys probably remembered. It lasted till May of this year, and it basically closed the border to migrants and asylum seekers under this pretext of addressing COVID-19. It did not close the border to me or to anyone from the United States going into Mexico and leaving however we wanted. The border was absolutely open, but for some reason they thought that migrants would bring COVID-19 to the United States, but not white people or people with a US passport. So they closed the border for that. It was a public health law rule by the CDC, really, really shameful for all of us who believe in public health, that was used to basically keep people out of this country who needed safety.
I think it's still being fought, no?
Yeah, in court.
Still being fought in court right now.
And then now we have Title 8, so basically that the border is open for asylum for individuals, but really only if you make an appointment on this app we're going to show you in a second. And anyone they think doesn't have a reasonable asylum claim, they can basically do a process of expedited removal and allow you not to come back in the United States for 5 years. Anyone who crosses the border while waiting for an appointment or what they consider to be quote unquote illegal also can be subjected to this expedited removal and not allowed back into the United States for at least 5 years.
Okay, so the CBP app is full of errors. Like one of the first errors that was detected is that it needs to take a picture of the person. So it discriminates specifically against Black and brown people because they aren't detected when their cameras aren't that good. So a lot of people who were Black weren't getting the appointments because the picture was saying, take another picture, take another picture, take another picture. Right now, we have a chat with a lot of activists from the US-Mexico border that we give each other, now this is happening, now this bug was fixed, but now there's this other one. And it's always a new one. Like it's maybe a propósito, on purpose.
And the other thing about you have to understand about this app is like, who can use the app, right? It's people with more economic resources. You have to have a smartphone. You have to understand a language that this app has. You have to be in a place where you have internet.
Mm-hmm.
So you think about people camping along the river, you know, it's pretty hard. You need to make sure your cell phone is charged and all these things that are actually really difficult, especially for migrants who don't have a lot of money or standing. I mean, it's very difficult when you have no money to have a cell phone that's charged and connected to the internet. So it really excludes the most vulnerable people.
Well, and that brings also the always problematic extortion that people are, les están cobrando, people are getting charged money to fill the CBP app, even if it's free, just because they don't have the cell phone or they don't understand the language. And also it has a GPS that blocks people from being able to apply from the CBP from Mexico City to the south. So only if you're above Mexico City, you can apply to it. So trigger warning, there's a lot of bad things going on the border. So if you need to take a minute and go out, we totally understand. So Mexico has some really interesting health particularities. One of which is that, I like this term, forced immobility. We used to have forced migration or forced displacement. Now we have a forced immobility where people are need to wait in the border to get their CBP appointments or to get their Title 42 parole or something. There's always people that are coming to the north and getting stuck there. And that only brings more issues with shelter, with food, with water, and other types of services, including health services. So also, a lot of internal migration for southern Mexico has led to a lot of border cities, but specifically Tijuana, to experience one of the highest population growth rates in Latin America. So population grows, but the hospitals are still the same. We only have one public hospital for 2.5 million people. That's Tijuana population. And as well, a major road for migrants to go there. Also a major drug trafficking route. And a special issue with two border cities, that's Ciudad Juárez and Tijuana, that we have a lot of heroin users, intravenous drug users, and also 95% of the heroin that's used here and the methamphetamines that are used here in the US come from Mexico. So it's this thing that always comes around that it's not a deal between people that want to migrate, drugs and weapons. So migrants have become like another coin to share, to deal. And yeah, lots of drug users. That comes with certain needs in public health. So the public health system, the president likes to call it universal health care, which is written like that in the Mexican Constitution, but it's really not, because Mexico doesn't have the sufficient resources to deal with all Mexicans. and that's just it. But even if it's bad for Mexicans, it's even worse for migrants. Because some migrants get stolen their IDs, their papers, all their full backpack that they were trying to get to the US. We have documented some cases where police or military are the ones that are stealing and taking to the trash these documents. So when you don't have an ID, how do you access a public health system, even if it's free, And then is the private services. The private services are directed for people, probably most Americans, especially in Tijuana and the border cities. Lots of Americans go to Tijuana to the border to get treated. And then there's the other option like us, who NGOs take care of a lot of the healthcare of these people. Okay, so we have some cases that we've seen directly. I'd like to start with deportees. Deportees in Tijuana live in a canalization of a river and under bridges. And a lot of these deportees are intravenous drug users. And it's like they don't exist. There are thousands of people that are deported from the US and are not even from Tijuana, but stay there because all their family is in the US. So they want to keep close to their family that's in the border. So they stay there and they are incommunicated, they are depressed, they are a lot of other health issues. And some of them were even drug users before coming into Tijuana. So they come to Tijuana and they get hepatitis C, HIV, and a lot of stuff that is not treated by the government, only because they because they live on the street or rough sleepers. The other case, Joel, this person that you see there, the adult one, was a patient of us. He was going to get married to his Mexican girlfriend. He was in Tijuana since 2016, when the first diaspora of Haitians came from the earthquake and the hurricanes. So Joel wanted to get married, but he was beaten by the police. And we were called to buy medication for him because he had cerebral edema. And we did, and we then tried to help us como podíamos, as we could. And he was discharged from the hospital without with the brain showing, and without being able to speak, without being able to walk. And he used to work selling stuff in the street, at the border actually, at the line house. And well, he won humanitarian parole, but he shouldn't have, because the police did this to him.
Yeah, we eventually had to cross him to some family members because it was just too hard to take care of him in Tijuana. He was not getting appropriate rehabilitation services, but that really wasn't what should have happened with him, because he had a partner and other people who loved him in Mexico, but there was no way he was going to be able to get the proper care if he stayed in Mexico. And the other case down below is a little boy that we helped, who actually we tried to get across the border because we were told he had leukemia, and he kept needing frequent transfusions. And when I met him, he was running around a shelter. He was like doing okay, but I knew basically by, you know what happens, like if you don't get treatment for leukemia, right, you start having all these issues with your electrolytes, with your cells. We'll learn about this later on, but the result is that you can go into really severe crises and die because of that. And also you're just immunocompromised. He's living in a shelter with hundreds of other people, worst place possible for him to be. We asked CBP so many times to let this kid cross, they didn't. He ended up intubated on a ventilator on multiple blood pressure agents. And we basically had to call people at the White House through every channel we had to get this kid across, which he eventually did. He got, luckily, most hospitals denied us, but this one fellow from this one hospital, let this be a lesson to you all, you could be that one fellow. She like didn't ask permission, thank God. And they didn't say no to her until she was already on the way on the chopper. So she was like, well, I'm already on my way, I already accepted this kid. And so they took him back to, actually it was at CHOP Orange in Orange County. He coded a couple times. He almost didn't make it, but now he is alive and well and got a bone marrow transplant. And they were able to finally diagnose him with this very rare condition, but he's probably gonna survive. And it's just an example of like, as doctors, sometimes even if you're talking to your own government saying, listen, we know what we're talking about, they do not listen, and it can lead to, I mean, it's a miracle that he survived. That's a positive case. We've had a lot of other patients who have actually died in the same system. So this is kind of like where we do our outreach in refugee camps and shelters. Some of them are outdoor encampments, some of them are inside encampments, and these are kind of the conditions under which many people live. In Tijuana right now, most people live inside of shelters. Some of those shelters are, you know, bigger or nicer or have beds, and others of them just have tents inside them or mattresses on the ground. In Reynosa, where we now have a clinic, it's there's a lot of outdoor encampments along the Rio Grande, which the conditions are much worse, very little sanitation or hygiene.
You know, there are shelters without any bathrooms, without any showers, pregnant women there, little children, and it's just across the Rio Dam, Rio Bravo? Right, and in Spanish we call it Bravo, so it's the same. And I've seen the military pointing like large guns towards the encampments. That's what they do. And they put out high like messages that don't cross, it's illegal, don't cross at 3 a.m. until 5 a.m. And they put alambre?
Like barbed wire.
Barbed wire in the middle of the river so people wouldn't cross, and people have died there. It's different when you cross to Tijuana. I hope you do, to come help people. And it's different when you go see to the east part of Mexico, because it's not mentioned even the problem there. So people look to Tijuana and give us funds for Tijuana, but it's not enough, because the problem is all over the border. So the conditions are really different shelter to shelter, but the worst conditions even don't have communal toilets. Having communal toilets is like a plus. Some of them don't have electricity, don't have access to vaccines, and in some shelters, they don't even want to go across the street to get medical attention, because narco people kidnap people, migrants, to ask for money from the people that are in the US, that are their family. So they keep getting kidnapped. And well, usual issues like cough, rashes, diarrhea, and lots of bug bites.
Yeah, you have to understand that migrants, like in the global context, are really just seen as like surplus capital. They're people that don't really matter, and that sometimes can be used as like basically an asset or a resource, but when they're not, they can just be dispensable or disposed of. And that's how it kind of works in the capitalist system, that there are these people that are just considered kind of surplus and not, you know, you don't really have to take care of them because they're just supposed to be workers, and, you know, they can be used for as commodity, but when they're not, they're just really dispensable in the system, and no one seems to care all that much. These are just two articles you can take a look at in reports, and it just goes to say that all these policies we have in the United States, they have real effects. So these are two that looked at migrant protection protocol that we talked about earlier, and both of them showed that they basically caused horrific harm to people's mental health, especially childhood mental health, but also adult mental health. And that those, you know, the effects of mental health can be long lasting. They've done a bunch of studies now that show that PTSD can completely rewire your brain and actually cause you to die young, earlier than you would have. And so all these things are basically just reinforcing policies, reinforcing health inequities, and, you know, traumatizing and damaging people long term.
Okay, so RHA tries to, well, we have a model of care that we try to be trauma informed. And when we talk to students, when we talk to policymakers, with anyone, we try to make a point about it because it's so important. And specifically for our patient population, but for everyone, and not only in healthcare, but in all types of services. So the trauma that can be towards our patient population, because they have like a new culture, limited resources. And the thing is that you need to look specifically for symptoms that are like así, no como inespecíficos, unspecific,
It's not like, not very specific.
not
symptoms.
specific symptoms, like back pain or a headache. But also isolation, anxiety, fear, that's seen like normal, they're anxious, they're migrants, but this comes to a lot of other bodily effects that you need to know so you can detect it.
And for you guys here in like, us in the United States, I mean, even me, who I work down in Tijuana, like I'm very well informed. Like I miss this sometimes when I'm working in the ER, because you're just trying to get through patients and someone just has a somatic symptom and you do a workup and it's negative. And you're like, oh, you're fine. Like, all in your head or whatever you're doing. And the thing is, if you don't actually think about it, like, oh, and ask those questions of people of like, oh, so how long where do you live? Like, how long have you lived there for? Like, what are the things that are going on in your life? What's new? You're not going to catch it. Like, it takes multiple questions to understand. And a lot of times people will be like, oh yeah, I just got here a month ago, and I was in detention for, 3 weeks and, I haven't been sleeping or eating as well. And that's why they have these symptoms. If you don't address that, then you're not going to address the underlying cause. So this is just for our organization that we helped found. This is our basically vision statement. I think the most important thing that we do is that we're really trying to work toward a world in which every individual has a right to stay, the right to move, and the right to return in the pursuit of health and wellness. And we're going to talk a little bit more about that at the end of our presentation, but we try to practice all the principles that we believe create truly good care for people and not reproduce the systems that we believe are not creating good care in the systems that we have worked in traditionally in the United States and Mexico. So these are some of the sort of things we do. We have shelter outreach. So this is we go to the shelters every Saturday. In Reynosa, they go to the shelters more frequently, but we bring a bunch of volunteer physicians and our local physicians that we've hired in Mexico. And we try to see people in the site in places in which they're living, which is super important because some people don't leave shelters for a variety of reasons. And if you don't go to the places people are living in, some of those patients are never going to be seen, like that little kid with cancer whose mom probably wouldn't have come to our clinic. And then we have 4 clinics right now, 3 in Tijuana that are all kind of close to each other, Justicia en Salud, Resistencia en Salud, and Paz en Salud, that kind of have different functions, but try to provide very holistic care to people so that they can kind of choose what services they want and how they want to interact with us to try to give people back a little bit of autonomy in selecting what type of care that they want. Certain populations of people want more naturopathic medicine, other people want Western medicine, other people want a combination of both, and we try to provide that to them, as well as some really good mental health services. And then in Reynosa and maybe soon in Matamoros, we just opened a clinic in June called Revolucion en Salud, and we just started some of our services there and hope to reproduce our model that we have in Tijuana over in Eastern Mexico. We also really try to address structural and social determinants in systems. So we have a hygiene project, so we provide bathrooms, toilets, laundry to people who are unhoused or living in tents on the streets. Migrants and deportees are most of our patients. We provide medical legal services in conjunction with a few organizations, including Al Otro Lado, which is a fantastic organization in Tijuana and Los Angeles. We also do a lot of LGBTQ+ care. Since the beginning of the organization, a lot of people who founded it fell into this community. So we've always provided gender affirming care and always really focused on this specific community and have several grants that support our projects. Tijuana has kind of become the place that you go if you're a trans or queer migrant, because there is us giving healthcare, there's a legal organization, and there's 3 shelters. We also work with some UCLA doctors who are part of the LGBTQ clinics who come down and assist us with that at times. We work with like local food banks that are autonomous food banks to provide food on site and at encampments and shelters. We provide portable water because there's no portable fountains in Tijuana. And then we provide mental health services, social work, and we have some HIV and TB collaborations with local organizations in order to really provide as holistic care as possible. This is one of our more recent things that we did about 2 years ago. So these are our showers and toilets where people can kind of take a shower, or go to the bathroom in peace and dignity. And most of the shelters, there's not an actual door on the toilets. There's not actual doors on the showers if they have them, if there are any showers at all, and there's certainly not hot water, and we have all of those things. So it kind of helps people just get back into a space where they can feel better about their situation. And then we really try, as part of our organization, to not replicate systems of power, which means that we're a non-hierarchical organization. We try to be, at least, which is very difficult, I have to tell you. There's no roadmap to try to be non-hierarchical, but we've found that if you are more non-hierarchical in your intent, you end up not just disposing of the people at the bottom who sometimes have the best ideas and are able to create and revolutionize your organization in ways that are not possible in hierarchical organizations. I'm sure you all felt this as med students. Trust me, I felt it as a med student, where it feels like your thoughts and opinions don't matter, but like there are other ways to practice medicine that don't replicate this. And that's something that we're trying and sometimes failing at doing, but then trying again. I think it's a really important practice because every single person on the team is very important, and we truly believe that, and especially because we're working across borders and with people from really different backgrounds. And these are just some pictures of us.
What you could be doing if you volunteer with us. Look at the fun faces. Yeah, they're having a great time seeing migrants. No, it's a great opportunity. If I was a student, I would have loved to come and learn, and there's so many types of clinical things to learn, but also community and seeing how it can be done differently.
And then just a comment on, I think CK and I are both very clear that humanitarianism cannot lead to structural change. What we're doing is humanitarianism, and we try to do it as revolutionarily as we can, but that's not going to take down these borders, and it's not going to stop migration or create an environment in which everyone can migrate. And so really, in addition to doing this work that we do, we also as an organization try to advance the efforts towards border abolition, which we truly think is the only way to create health equity. And I think, you know, it doesn't necessarily, like people are like, oh my God, border abolition, don't say that, everyone's gonna freak out. But the reality is it doesn't, like, border abolition isn't like, oh, we're gonna go like tear down this wall today. That's not what it is. But it's really about exposing the systems that create borders and make them necessary. Like if you really think, like, why is this border necessary? What is it actually doing? And in a lot of ways, it's separating those who have from those who have not. And I think that is like the very, like when I realized when I realized personally that I could just cross this border, no one looked at my passport, and then cross back over and they look at it, but they don't really care that much. And they have these patients who are just trying to live, who can't just do that. It's an incredible reflection of your own life and your own power and privilege that all of us have who are on like this side of the border. No matter whatever vulnerabilities that you have in other aspects of your life, it is an incredible reflection on that. And I think, you know, this is just like the diagram I always have, but it's like, we're really just, it's very simple. Border abolition is simple. It's like the ability to move. It's the ability to stay, and it's the ability to return, which is something that most of us, maybe not everyone in this room, but I would say the majority of people in this room have. And we cherish, like, I enjoy that I have a place that I can always live, and if I want to go someplace else, I can, and then I can come back to it, and no one is stopping me. So here's just a few like thoughts about how to move towards liberatory solidarity that we came up with. So, you can talk to others about borders as places of oppression. You can do the work, and you can also do the work for free. That's how I do the work. And you're not really there to save anyone. You're showing up to be working in solidarity with other people. You can just transition health work from clinical spaces to more shared spaces, to more abolitionist spaces with other community organizations and groups. And you can acknowledge your own complicity with and challenge the global infrastructure that drives displacement. And then lastly, like here in the US, you can, challenge people and also provide trauma-informed care for patients in the US and abroad. And this goes for not just the US-Mexico border that we're talking about right now. This goes for like all the borders in all the world that are creating this inequity and leading to people being displaced or being killed or being, removed from the planet or being not allowed to move.
Bombing hospitals.
Or other things that are truly not in alignment with creating an environment or a world that's healthy. So that's the end of our presentation. So we have some time for questions. Yes.
Hi, thanks for your time. This is very much appreciated. This was really, really great. Thanks for opening our eyes a little bit and giving us a little more direct information. I was wondering if you could speak a little bit to the cultural complexity of like actual healthcare delivery. That was kind of mentioned, like some people prefer more traditional medical practices and more indigenous medical practices. Some people prefer a more Western framework. Could you just speak a little bit to like how you all work with that specifically, whether that is like unique staff or local, like just the ways that you kind of make sure that you're having all the possible types of care that people can want with that.
It's a constant struggle. It is, because we have the framework, the cultural mind of physicians like me and the team in Resistencia and the team that does the acupuncture, the naturopathic medicine. So we have to be in constant talking. We have to talk, and that's something that we are not taught of in medical school, at least in Mexico, or no here. But so to talk to people that do stuff like tea for, I don't know, hypertension, it seems weird. But then I need to go and understand and be humble and practice cultural humility. And cultural humility is that trying to open your eyes to what other options are to the things that you're doing. And there are other things that allopathic medicine cannot do, like a lot of things that are trauma, that arise from trauma, like chronic pain, chronic headaches. You can't do anything about that. I mean, Tylenol won't cure that, but acupuncture does. And we have learned that and need to study it, and we need to work with each other. And we try to lead our team to know what the other team is doing and offer what we have as options. Because one of the things that you can do to empower your patients always is to give options. Did I answer this?
Yeah, I have a quick follow-up to that though. What is the, like, if there's a training per se, like what does it look like for the people that like newer volunteers to have that sort of knowledge and understanding of, especially if let's say some of us are coming with only that Western framework, to as quickly and efficiently understand the nuances culturally within like healthcare delivery in the area? Is there like training, or how does that work?
One of the things we try to do is try to have people rotate at the different places that we provide care. Our clinics are right next to each other, but they're right, like there's like a hallway between them, so they're very close. But there is like, there is distance, because I mean, I wasn't taught any of this school, neither was CK. So a lot of it was like learning and understanding about it. And I think the best way that I learned and understood about it was to like spend time with the people who were providing this other type of healthcare that I didn't understand. And so we try to have people rotate through the different clinics and the different like care environments so that the people who are doing the care that they're doing can teach them. Like, this is why we do this, and this is like how you can provide care separately. I can give you like an example. I, you know, as an ER physician, like I mean, home birth like kind of freaked me out. And they're like, the midwife was like, you should just come to a birth with me. And I went, and like the first two things she told me were things that I had never even thought of before. So before I walked into this birth situation, she goes, there are two things that I do differently that I tell everyone that I want to be really clear about before you come to this birth. And the first is, I never yell at a woman to push. And you guys are going to go to some births, and every single birth I ever went to, someone was yelling at a woman to push. And she was like, I think it's traumatizing to women to be yelled at to push. Women know when to push. You can guide them, you can coach them, you can yell at them to push if they ask you to, but otherwise I never yell at a woman to push. And like, that was crazy to me in my head because of the environment that I had been exposed to in Western medicine. The other thing is that I never give someone the baby until they ask for it. In the United States, you'll see the first thing that anyone does when a baby comes out is throw it on the mom. And she's like, a lot of these mothers have been through a lot of trauma, you know, and they're not ready to receive the baby yet. Like in indigenous tradition, people will pick up their baby after they gave birth at home. They'll pick it up when they're ready. And like, they don't need to get it right away. So I always wait for the mom to ask for the baby when they're ready, because they just gave birth, you know, the baby doesn't need to go right there. Someone else can hold the baby. Like, that's important, but you don't have to throw it onto the mom's chest. And so, I mean, I think it's just like being and practicing in that environment. It kind of like the questions that you ask and the things that you see are different. And that kind of allows you to learn in just like a natural way, a different way of doing things, and then question the ways that you've been taught to do those things, like in your own like school or setting.
And we grab that experience that we built and write it or do videos for our onboarding process. And we are constantly giving social justice classes to our staff because a lot of people don't know about this, and it's okay. We can learn. We can all learn.
Yeah, I was wondering if you could elaborate more on what happened with like the fellow with the child with leukemia. Because I guess like I'm kind of ignorant. Like, I guess like what did that fellow do to allow that like authorization to actually happen?
So basically, the issue that you run into is a monetary one. You know, as soon as the CEOs of the hospital find out that a child who may not qualify for Medi-Cal is going to be in their care, and they might have to assume the cost of that child's treatment, the attitude changes. We didn't get no's from doctors. We got no's after the doctors were trying to get that approval from the CEOs. I can tell you UCLA said no. I can tell you that the county hospital said no. I can tell you that UCSD said no. Well, they didn't say no. They just kept saying they had no beds, even though we knew they did. So this fellow, we talked to them, and she said, yeah, that's fine. And I think it was like a really quick thing. We were like, we could bring him across right now. She's like, yeah, we'll get in the chopper. We'll come get him. And I think by the time it like filtered up to the CEO, she was already on the chopper. There's nothing they could do about it. But really, it came down to money. About this kid, whether it was considered an international transfer, which it shouldn't be, because the kid crossed the border in an ambulance and then was in the US, so really they're in the US by then. But trying to explain these particularities of the border to people who don't understand border at all was very, very difficult and incredibly frustrating when a kid is dying in front of your face. So that's what happened. I'm not sure she intentionally did it, but she was glad that she did it. And I think she understood that, like, and she didn't turn back. She was like, no, I'm going to get this kid. I made a promise. And I think they were able to qualify him for Medi-Cal after all of that. And most of his treatment was probably covered by the state. But there is an issue with international transfers, what they consider to be international transfers, which it wasn't.
Hi, my name is Jocelyn with Comedy Garcia. I grew up in Tijuana. I grew up in La Sylvia Rojas, and maybe you've heard of it. It's this displacement community where a lot of refugees are deported from America go live there. There's a lot of people who are transgender that have mental issues like my mother. and we receive help from people like you. And I just wanted to tell you that thank you. I am here because people like you inspire me to come into medicine. I am here because people like you leave their houses, their city to provide care for people that were neglected. And I just want to tell you that. I've had the chance to tell the doctors that treat us, thank you. So on their behalf, thank you very much.
Gracias. Gracias.
De nada.
More questions? Comments? Or-
Can we go back to the way we can get involved?
Oh,
Yes.
yes.
Yeah, so this is our website, and if you go on, that's CK's email address, mine is just Janeway.
If you want to volunteer directly, you go to rha.volunteerhub.com. And there you will get all the different types of volunteer opportunities that you have with us.
Yeah, and there's a link from the website to the volunteer hub, so. And there's a lot of UCLA affiliated providers and med students who come down and volunteer with us, especially on Saturdays, which is usually the best way to come volunteer. And we also host some of the students as part of their
Global Health.
global health and
Rotation.
discovery experience.
Discovery and then MF4 too.
See,
Yeah.
MS4.
People can rotate down there.
Yeah, and people have told us that they've learned so much clinical stuff that they didn't even see in school. So it's not only understanding the culture, understanding the patients, but it's also very good clinical teaching because we're there hands-on and with a patient that we can spend time with, and you usually don't have that.
I just want to clarify, would these clinics be in Tijuana?
You can go to Reynosa too.
It's a little bit more dangerous, but you can go.
I go. Listo. Thank you. Creo que mejor que la otra vez.
Yeah.
El año que entramos al-
Yes.